Okay, now let's talk about osculating the heart for just a second. When we talk about auscultation, remember there's 5 general places where we listen to the heart at. The first place that we listen is actually the aortic point, and that's actually second intercostal space, just right of the sternum. When we listen over that first point, the aortic point, the big thing that we're able to auscultate here is aortic murmurs of a systolic nature. So if the patient has got a systolic aortic nature, we're most likely to hear it there in the aortic, at the aortic point of auscultation. Again, second intercostal space, just right of the sternum. Now, just straight across the sternum on the other side, second intercostal space, just left of the sternum is our second point of auscultation. That's the point of where the pulmonic valve is, or the best place to auscultate the pulmonic valve. And here we have our best ability to auscultate both systolic and diastolic murmurs of the pulmonic valve. Now, if we just go one rib down, that brings us to our third point. And our third point is Erb's point. And there's 2 big things that we can hear at Erb's point. The very first thing that we hear at Erb's point is any kind of diastolic aortic murmur. If it's a diastolic aortic murmur, we usually hear that at Erb's point. And then the second thing that we hear at Erb's point is actually friction. If we've got like a pericardial friction rub, like if we've got pericarditis, we're most likely to hear that at Erb's point. Now, if we go one more rib down, that brings us to our tricuspid point. And at the tricuspid point, obviously, the best thing we can hear there is any murmur that's related to the tricuspid valve. And finally, if we go over one more rib, and then we go over just a little ways to where we're sitting, like where the medial third and the next third of the clavicle come together. So in other words, if I broke the clavicle into 3 parts, where the first part and the second part come together, if we go straight down there, then what we'll hear is actually the mitral point. And the mitral point is actually where we would hear most of our mitral valve problems. But this is also a very important point for us to listen, because this is also where we are most likely to hear an S3 sound or an S4 sound. Okay, so let's talk about what we normally hear when we listen to a heart. In a normal, healthy heart, a lot of times we'll actually hear an S1 and an S2. That's normal physiology. When we talk about the S1 sound is actually caused by the closure of the atrioventricular valve. So the S1 is caused by the close of those valves as we start systole in the ventricles. So as the ventricles start to squeeze and blood starts to move out into the great blood vessels, some also wants to move back, that slams those AV valves shut. And that closing of that valve is what creates our S1 sound. Now, the S2 sound is actually when the semilunar valves close. So the S2 sound is when the blood moves up into those blood vessels, both into the aorta and the pulmonic artery. Those arteries both expand and rebound, and when they expand and rebound, that slams those semilunar valves closed. So that's our S2 sound. And remember, S1 and S2 are completely normal. We expect to hear those sounds in a nice, healthy person. Now, the third sound that we can hear is actually something called an S3. And when we hear an S3, it comes right after an S2. And the classic way that you'll hear people describe it is they'll describe it as sounding like the word Tennessee. So you'll hear like Tennessee, 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 or dun-dun-dun, 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 dun-dun-dun. That's classic with an S3 sound. Now, the thing you need to know about an S3 sound is in people less than 40 years old, it's not uncommon to hear an S3 sound in a completely normal heart. Especially if they have a really healthy heart, like your athletes and stuff, a lot of times will have a normal S3. Where we really care about the S3 is in older people. Once you're over about 40 years old, it's not normal to have an S3, and the older you are, the more abnormal it is to have an S3. So in people over 40, an S3 suggests to us that the ventricle has an excessive pressure. So as people start to go into CHF, as we start to see congestive heart failure, or we start to see left ventricular failure in older people, they will develop an S3. Now, the other type of sound that we commonly hear is something called an S4. And an S4 actually occurs right before S1. And so the way that you hear people describe an S4 is it sounds just like the word Kentucky. Kentucky, Kentucky, Kentucky. And when we talk about S4s, S4s are caused by the fact that blood is trying to be crammed into a ventricle that is already full. So while an S3 in an older person suggests that they're starting to get CHF and that CHF is progressing, when that CHF becomes really bad, when it becomes really significant, a lot of times we'll see the S3 will go away and they will develop an S4. Now, when we talk about murmurs, remember that murmurs are caused by turbulent blood flow. And when we talk about murmurs, we grade them from 1 to 4. And so a grade 1 murmur means that you can barely hear it. Like, say we're listening for a pulmonic murmur or an aortic murmur. If we can barely hear it, we have to focus really, really hard to hear it. We would call that a grade 1 murmur. In contrast, if the murmur is so loud that I don't even got to put my stethoscope on the chest, I can just get my stethoscope like close to the chest and I can hear it, then that would be a grade 6 murmur. So again, grading goes from 1 to 6. 1 is barely audible, and a grade 6 murmur is a really, really loud murmur. Okay, so let's talk about blood flow now. When we talk about blood flow, remember that when we talk about blood flow, 70 to 80% of unoxygenated blood flows from the vena cava right into the right ventricle. Remember, we already talked about on the right side. As blood is coming into the right side of the body, most of it is going right down into the right ventricle. Only about 20-25% of our blood actually, of our cardiac output actually comes from atrial kick. But that atrial kick is still pretty substantial. 20 to 30% is a lot of blood. Now, when we talk about that transition of blood from the right atrium to the right ventricle, we know that normally the tricuspid valve is sitting open, so that's normally a passive thing. And then again, as the right ventricle contracts, that's what slams the tricuspid valve closed. That's what creates our S1. And as blood goes out into the pulmonary arteries expand, and as they expand and rebound, that closes the semilunar valve or the pulmonic valve and creates our S2. Now, on the left side, remember that the left side is under a lot more pressure than the right side is. Now, when we talk about the left side, it's just like the right side in that most of the time, most of your blood is going straight from your pulmonary veins right into your left atrium and plotting right down into your left ventricle. It's just that last 20 or 30% that actually comes from the kick of your left atrium. Remember that that as the left ventricle contracts, that squeezing makes blood want to escape any way that it can. The blood that tries to go retrograde slams the mitral valve closed, so all the blood is pushed out the aorta. As blood goes out the aorta expands, and as the aorta expands and rebounds, that slams the aortic valve closed, which causes our forward movement of blood. So when we talk about cardiac output, remember that cardiac output is made up of two things. It's made up of heart rate and stroke volume. And when we talk about a normal cardiac output, a quote-unquote normal cardiac output for an average size adult, we would normally say that most adults will put out somewhere around 4 to 8 liters per minute. If you remember, total circulating blood volume for an average adult is about 5 liters. So in a normal healthy person, roughly 100% of your blood is going to be circulated every minute. Now remember that when we talk about cardiac output being all about heart rate and stroke volume, the easiest, fastest way for us to increase our cardiac output is to increase our heart rate. But that has a finite amount of benefit. Once we increase the heart rate, the faster we increase the heart rate, the more work we put on the heart. The other thing that we have to remember about the way the heart works is as blood is squeezed out of the left ventricle and up into the aorta, as that aortic valve slams open for blood to move up in the aortic valves actually block what are called the coronary ostia, which are the holes on the sides of the aorta, which is where blood flow to the heart goes to. So when we're in systole, we actually don't get very much blood flow into our heart. Instead, the heart gets most of its blood flow as that aorta expands and rebounds and slams the aortic valve shut, and blood is forced down the coronary arteries. So most of the heart's perfusion actually comes during diastole. So while tachycardia is the fastest way to increase our cardiac output, it is also the most damaging way to improve our cardiac output, because the faster the heart beats, the more time we spend in systole, the less time we spend in diastole. So what does that mean? That means we spend even more time in cardiac work, even less time with the heart getting the perfusion that it needs. Okay, now what about the stroke volume side of things? Remember that in adults, they also have a fair amount of ability to increase their stroke volume. In children, we see that children are really kind of limited, especially little ones, are really limited by their heart rate. So we don't see a lot of ability to dramatically increase stroke volume in children, but we do have a fair amount as adults. When we talk about an average stroke volume, quote-unquote average for an adult, we usually say that's somewhere in the neighborhood of like 60 to 135 cc's. And the other way that we measure stroke volume is with something called the ejection fraction. The ejection fraction is what percent of the blood is actually pushed each time I squeeze a ventricle. And so how much of it is actually moved out of the ventricle. And for an average size, nice, healthy adult, a normal ejection fraction is somewhere around 55 to 70%. So about 55 to 70% of the blood that's in your ventricle is going to be squeezed out into the blood vessels, assuming that everything is healthy. Now, when we talk about stroke volume, remember that stroke volume is also made up of three things. When we talk about stroke volume, the first thing that makes stroke volume is something called preload. Preload is how much stretches on the ventricle when it's sitting at rest. So in other words, right before I start to contract, how much blood is sitting in that ventricle. And obviously, the more preload there is, the more stretch there is, the better we are to, the more ability we have to contract to a certain point. As we increase preload and increase preload and increase preload, it goes back to that whole Frank Starling mechanism of the heart. If I stretch the heart and stretch the heart and stretch the heart, eventually it gets to the point where it doesn't have the ability to contract well. And so we want enough preload that there's maximum stretch that's going to get us effort. Once we go over that, once we go over the hump of that curve, then we actually get to the point where there's too much preload and we actually limit how well the heart can contract. Now, the other thing that, the other two components that play into our actual stroke volume are our afterload and our contractility. Afterload is what does the heart have to push against to get blood out. So a good example of an afterload problem might be like somebody who's all vasoconstricted. If I'm all vasoconstricted, if all these blood vessels are really, really tight, it's going to be really hard for my heart to push out. And so when I push out, there's going to be less blood that's moving. And if you know anything about like firefighting, you know why this makes sense. Because in firefighting, the bigger the fire hose is, the more water we can push. The smaller the fire hose is, the less water we can push. And also, the bigger the fire hose is, the less work there is on the pump on the fire truck, and the smaller the hose is, the more work there is on the pump on the fire truck. What's the same way with the heart? The higher our afterload is, the less cardiac output we're going to put out. The lower our afterload is, the easier it is for the heart to pump fluid out. Finally, the last thing that makes up our actual stroke volume is contractility. Contractility is how well can the heart itself contract. And when we talk about contractility, there's basically two things that make good contractility. We have to have all the electrolytes that we need in the appropriate places, in the appropriate concentration. So in other words, like there's got to be plenty of calcium, we've got to have potassium, but not too much, we've got to have sodium, but not too much, so on and so forth. And then the other thing we have to have for good contractility is we have to have good oxygenation and perfusion. There's got to be plenty of blood that's supplying the heart, and that blood has to have lots and lots of oxygen in it. Okay, now let's talk for just a few minutes about the electrical system of the heart. When we talk about the electrical system, remember that the electrical system is based on the very simple premise that whatever's fastest wins. So whenever we talk about what drives the heart, what's the dominant pacemaker for the heart, the dominant pacemaker is going to be whatever is the fastest pacemaker. And in a normal, healthy person, our fastest pacemaker is actually our SA node, which sits way up at high in our right atrium. And our SA node has an intrinsic rate somewhere around 60 to 80, depending on the book you read. Some books say 60 to 100. And because that is the fastest pacer, that is usually what's going to drive the heart rate. Now, if we look at electrical flow through the heart, as the SA node fires off, we have electricity that's distributed through the atria, and the atria contract, and electricity is also transferred through intranodal pathways down to something called the AV node. Now, the AV node is not designed to be a pacemaker. In fact, if the AV node has any job in life, the AV node's job is actually to stop electricity. That's its whole focus. That's what it's there for. And the reason why the AV node is so important is because by the electricity being moved from the SA node to the AV node and the AV node halting it, that allows physical time for movement of blood from the upper part of the heart to the lower part of the heart, from the atria to the ventricles. If we did not have an AV node there to stop that electricity, what we would see is electricity would go so fast from the SA node into the ventricles that we would have contraction of the atria, contraction of the ventricles, and the ventricles would have already contracted before blood had even had the time it needed to move down in the ventricle. So the AV node is really kind of important to us because it slows down conduction. Now, having said that, if the AV node doesn't get any direction, if the SA node isn't doing its job or something in the atria isn't doing the job, then the AV node does have the ability to function as a relief pacemaker, and we know that a normal intrinsic rate through the AV node is somewhere in the rate of like 40 to 60, so it can function as a pacemaker but at a much slower rate. Now let's look at below the AV node. As we go below the AV node, remember that we've got our electrical system for the ventricles, and when we talk about the ventricles, we have the bundle of His, and then right off the bundle of His, we actually have bifurcation into what are called branches, and we call these bundle branches. There's a right bundle branch and there's a left bundle branch. The right bundle branch is what's responsible for the vast majority of electricity going to the right ventricle. Now, when we look at the left bundle branch is actually kind of a misnomer because there isn't really, per se, any significant left bundle branch, because as we come off and we separate right and left, almost immediately after that separation of right and left, then the left separates into two more branches that we call fascicles. There's an anterior fascicle and there's a posterior fascicle. Now, when we talk about the right bundle and when we talk about the anterior left fascicle, both of those structures are very thin rope-like structures. Those structures are actually supplied by one blood supply. They're little tiny, little round structures, and they're very delicate. On the back side, though, when we look at the left posterior fascicle, the left posterior fascicle is actually more like a ribbon than like a piece of string. It's actually thicker, it's wider, and it actually has two blood supplies. So when we lose the left fascicle, we're in a lot of trouble. That means that we've lost two different coronary arteries. Okay, so speaking of coronary arteries, let's talk for just a few minutes about perfusion of the heart. When we talk about coronary perfusion, just to make sure that we're all on the same page, remember that coronary perfusion, the vast majority of it happens when the heart is in diastole. When the heart is in diastole, the aorta is expanded and rebounded, and as it's rebounded, blood has slammed the aortic valve shut, and thus the blood that wants to go backwards has no place to go but down the coronary ostia into the right and left coronary artery. So let's look at the left coronary artery first. When we talk about the left coronary artery, remember that the left coronary artery itself, or the left main as we call it, is a relatively short vessel. Right after we become the left main, very shortly thereafter we have a bifurcation. And at that bifurcation we have two major coronary arteries that come off. The first one basically goes down, basically goes inferior, and we call that the left anterior descending. The left anterior descending is what's responsible for supplying the vast majority of blood to the front of our heart. It's what's responsible for supplying the anterior side of our left ventricle. Now, at that split, we have the left anterior descending, and we have another blood vessel that actually wraps around the heart, and we call that the circumflex. The circumflex actually wraps around, going from medial around the left and towards the back, and the circumflex is responsible for supplying the left side of the heart. So it's responsible for supplying all of the left wall of the left ventricle. Now, in addition, in a certain subset of the population, in a significant amount of the population, roughly about 49%, the circumflex actually wraps all the way around and actually supplies the vast majority of blood to the back of the heart. Now, it depends on the book you read. Some books say 49%, some books say 40%, but we could say roughly half. Roughly half of people in the U.S., the vast majority of the posterior part of their heart is actually supplied by that circumflex. So if we lose the circumflex, if we have a blockage, not only do we lose that left lateral ventricle, but we also lose the posterior surface of the heart as well. Now, when we look at the right side actually is responsible for lots and lots of things as well. When we look at the right side, the right coronary artery branches off and travels basically straight down the right side of the heart. And as we look at what happens as we travel down the right side of the heart, one of the first things that we supply as we move down the heart is actually the SA node. The SA node gets its blood supply from the right coronary artery. So if we had an occlusion way up at the very top of the coronary artery, the right coronary artery, we would potentially lose that SA node. As we continue further down, we see it supplying the vast majority of the right atrium, also starts to control the blood flow for the right ventricle. Now, as the blood supply continues down and passes by the right ventricle, we actually see that the right coronary artery splits. And at the split, it actually becomes the right marginal artery and the posterior descending. At that split, the posterior descending is actually responsible for going around and wrapping around the bottom of the heart and again supplying the back of the heart. So we said that depending on which book you read, like 40 to 49% of people, the vast majority of their heart is supplied by the circumflex. Well, depending on which of those theories you buy into, then 51 to 60% of people, their blood supply for the vast majority of the back of their heart actually comes from this posterior descending, which comes off the right coronary artery. Now, going back to the split there, at the split, we said the posterior descending wraps around and covers the back of the heart. The other artery that comes off there is the right marginal, and the right marginal is what's largely responsible for supplying blood to the bulk of the inferior surface of our left ventricle. I'll say that again. The right marginal artery is what's responsible for supplying most of the inferior surface of our right ventricle. And it's really important that we understand coronary artery perfusion, because when we're looking at an EKG, we should not think in terms of like, is this an inferior MI or is this a posterior MI? I mean, we need to be able to diagnose that, but what's more important than that is we should be thinking in terms of, is this a blockage of the right marginal artery? Is this a blockage of the left anterior descending? Is this a blockage of the circumflex? And that sort of thing. That's really where the key comes into diagnosing an MI. Okay, now let's also talk about the actual thought process behind coronary perfusion, or the physiology behind coronary perfusion. We've already talked about the two major blood vessels and their bifurcations. Remember that the coronary arteries sit on the outside of the heart, and as they wrap around the heart, they have all these little arterioles that come off, and those arterioles basically just dive straight into the muscle, like almost at 90-degree angles. As blood flows from the outside of the heart towards the inside of the heart, those little bifurcations further split into more and more bifurcations, and that's what supplies the cardiac tissue. Now, the big thing to remember about coronary perfusion is that it's all about the laws that we've talked about in depth if you've already been through the respiratory section or if you've already been through the flight physiology section. In those sections, we talk a lot about something called Graham's Law and about something called Henry's Law. And those laws say that oxygen is always going to go from a concentration of higher pressure to lower pressure. And the more oxygen there is, and the more surface area there is, and the more pressure there is, the easier it's going to be for that to happen. And that's going to continue to occur. Oxygen is going to continue to go from the blood to the cells until there's equality. Well, as blood flows through the heart, as it goes from the outside of the heart towards the inside of the heart, oxygen is passing by cells. And as it's passing by cells, it's jumping into those cells. And it continues to jump into those cells until there's equality. So if we have an obstruction of a blood vessel, if we have a complete total obstruction, like if we have an MI that's completely blocked, say, the right coronary artery, then obviously nothing past that obstruction is going to get blood flow, thus nothing is going to get oxygen, and thus everything's going to be ischemic. But what about when there's just a partial blockage? Let's say that we've got a blockage of 95%. Let's say that we have a partial blockage, and so only 95% of the lumen of this blood vessel is blocked. Well, that means that there's still 5% of blood that's getting through compared to normal. Well, as that 5% is getting through, as it passes from the outside of the heart towards the inside of the heart, as it moves down the channel of blood flow, as it passes by cells, it's giving off its oxygen until there's equality. Well, that's going to continue and continue and continue until, guess what? There's not any oxygen left. And so blood's going to continue on its path, going from the outside to the inside, but now there's no oxygen left. So what happens to tissue on the inside of the heart? Well, obviously that tissue becomes ischemic. So while the tissue that was closest to the outside got oxygen and it's fine, the tissue closest to the inside of the heart, to the inner lumen of the heart, is what starves first. So that's how we understand coronary perfusion. Now, there's actually a mathematical way to calculate coronary perfusion. The formula that you'll hear cardiologists use is the CPP. Here, they're not talking cerebral perfusion pressure. They're talking about coronary perfusion pressure. The coronary perfusion pressure equals the diastolic blood pressure. Why is that? Well, because that's when the heart gets all of its blood, right? During diastole. So it's the diastolic blood pressure minus the left ventricular end diastolic pressure. Well, what in the world does that mean? Well, let's think about this. The left ventricular end diastolic pressure is how much blood is left in the ventricle when it's at rest. So basically, it's a measure of preload. Well, as my left ventricular pressure gets higher and higher and higher because my ventricle is failing and it can't adequately get everything out that it's supposed to, what happens to the ventricle? Well, the ventricle starts to get bigger and bigger and bigger. Well, what does that do to the stress on the wall of the heart? Well, that wall becomes thinner and thinner and thinner. Well, as that wall becomes thinner and thinner and thinner, what does that do to all the little arterioles inside of it? It slams them shut. It crushes them. It closes them. So in order to maintain an adequate coronary perfusion pressure, we have to give the patient enough of a diastolic blood pressure to overcome their left ventricular diastolic pressure and still have adequate pressure for perfusion. And kind of the magic number that you'll hear people talk about is a coronary perfusion pressure of at least 50. If the coronary perfusion pressure is at least 50, then that usually means that there's adequate perfusion of the heart. So, for instance, if we want to maintain a coronary perfusion pressure of at least 50 and the patient's wedge is 20, what does that mean their diastolic pressure's got to be? Well, if we add the coronary perfusion pressure of 50 to the wedge of 20, and remember wedge is just a measure of left ventricular and diastolic pressure, then we would come up with 70. So that would mean in order to maintain a coronary perfusion pressure of at least 50, the diastolic blood pressure would have to be at least 70. Okay, so let's talk for just a few minutes about the different types of infarctions. So we've talked about coronary perfusion and how that all plays, and let's talk about how different types of infarctions present themselves. When we talk about infarctions, the way that we used to diagnose infarctions was based on criteria that we would either call transmural or subendocardial. So we'll talk about the old transmural MI first. Now, before we talk about infarctions, remember the one thing to remember about an infarction is anytime we have an area of tissue that's infarcted in the heart, if we were to take an EKG lead and put it right up against that, what we would see is ST elevation. I'll say that again. If we've got an area where there's infarction, if I put a lead right up against it, I'm going to see ST elevation. In contrast, if I put a lead on the other side of the body, I'm going to see the exact opposite. So I'm going to see ST depression. So wherever the infarction is, the lead right up against it, EKG lead right up against it, it's going to show me ST elevation. On the other side of the body, I'm going to see ST depression. So when we talk about what we used to call a transmural MI, what that would denote is that we had complete occlusion of a blood vessel. That means the entire blood vessel has been occluded. And because the entire blood vessel has been occluded, everything that was supplied by that blood vessel is going to be ischemic. So for instance, you see the occlusion there on the graphic down below. You see the occlusion takes up the whole blood vessel. So everything that's in the orange area is an area that's not getting blood flow and therefore is becoming infarcted. So if we put an EKG lead in that same area of the heart, let's say for instance, just for example, that this was on the anterior surface of the left ventricle, if we put an EKG lead right up against it, we're going to see ST elevation. In contrast, if we were to take EKG leads and slap them on the back of the patient's chest, on the opposite side we would see ST depression. So the hallmark of a transmural MI is ST elevation and ST depression in the opposite leads. And we call that ST depression in the opposite leads, we call that a reciprocable change. Now the second type of MI that we could actually have is something called a subendocardial MI. And so when we talk about a subendocardial MI, this is the patient where there's a partial occlusion. So for instance, let's say that this occlusion is blocked 95% of the blood vessel. Because it's blocked 95% of the blood vessel, only 5% of blood can get through. So the 5% of blood that can get through is always going to feed the outside surface of the heart first. As we continue on in, what we're going to see is that the more internal we go, the more we go towards the actual inside of the heart, the more ischemic the tissue becomes. So we see that in this example, in a subendocardial MI, this patient's ischemia is all on the inside surface of the ventricle. Now, again, remember that wherever there's ischemia at, or wherever there's infarction at, I should say, we're going to see ST elevation. On the opposite side, we're going to see ST depression. Well, if we actually had the ability to stick an EKG lead inside the ventricle, if we could actually take an EKG lead and stick it in the ventricle and put it right up against that area, we would see there would be ST elevation. But we don't have the ability to do that. But we do still have the ability to put EKG leads on the outside. And so when we put our EKG leads on the outside with this type of MI, with this subendocardial MI, what we're going to see is ST depression. So remember we said there was two things that caused ST depression. The first reason why we would see ST depression is because it's a reciprocal change, because there's ST elevation in another lead. So if we have ST elevation and ST depression, ST elevation always gets more attention. That's the bigger issue, because that tells us the full thickness of the muscle has been involved. But if we make a sweep of our EKG and we don't see ST elevation anywhere, but we do see ST depression in two or more contiguous leads, then what we used to call that was a subendocardial MI. Now, the third type of MI that we can actually have is something called unstable angina. And I say MI, really I should be saying acute coronary syndrome. The third type of acute coronary syndrome we can have is something called unstable angina. So what diagnoses unstable angina? Well, unstable angina, the thing that diagnoses it is the patient, like your patient who's having a subendocardial MI, just has a partial occlusion of a blood vessel. But the occlusion is small enough that almost everywhere in the heart can get perfusion except for one little tiny area. And that little tiny area a lot of times is so small that when we do an EKG on these patients, it's normal. A lot of times what we see is these patients actually have a normal EKG. If we do see EKG changes like ST depression or something like that, a lot of times it's just transient, like it'll be there and then the next EKG it's gone. So this is you can almost think of unstable angina as being like a really, really small subendocardial MI. Okay, now let's talk about the way that we classify this stuff today. We talked about how we used to call things transmural MIs, subendocardial MIs, and unstable angina. Nowadays, first off, we don't call it an MI, we call it an acute coronary syndrome, and we talk about acute coronary syndromes based on three classifications. The first classification is unstable angina. So what do we have to make the diagnosis of unstable angina? Well, the first thing that we have to have is some reason to think the patient's having an acute coronary syndrome. For instance, they're having sudden onset chest pain, they're having shortness of breath, they've got pain radiating up into their neck or in their arms, blah, 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 blah. We all know what acute coronary syndromes look like. Now, when we put the patient on the EKG, what we should see is that there's either poorly defined transient 12-lead changes or there's no 12-lead changes. And there's been a change in the way that we used to break these down. Now, currently, what we say is that with unstable angina, the patient has negative cardiac markers. So I'll say that again. Based on the most recent guidelines, the 2007 guidelines, we say that unstable angina is the patient who has symptoms suggestive of an acute coronary syndrome and a normal EKG or transient EKG changes that are poorly defined, and the patient has negative cardiac markers. Okay. Now, the next level of MI that we talked about before was we said the subendocardial MI was that patient who has a partial occlusion and so just the inner surface of the heart is starving. Well, we no longer call that a subendocardial MI. Instead, we now call that a non-STEMI acute coronary syndrome. So what do we have to diagnose a patient with a non-STEMI? Well, what we have to have is ST depression or dynamic T-wave changes in two or more contiguous leads, and the patient has to have positive cardiac markers. Now remember that your cardiac markers are going to take several hours to come up, so that doesn't mean we wait around to see if there's positive cardiac markers. If we have ST depression or dynamic T-wave changes in two or more contiguous leads, then the patient has a non-STEMI until proven otherwise, and we start working the patient up as such. Now, going back to our old classifications, remember when we said we had a transmural MI? That was when there was a complete occlusion of the blood vessel, and so the entire wall of the myocardium was ischemic and was infarcting. Well, we no longer call that a transmural MI. We now call that a STEMI, or an ST segment elevation MI. So what do we have to have a STEMI? Well, we have to have ST elevation in two or more contiguous leads, or, and this is really important, or a new onset left bundle branch block. If the patient has a new onset left bundle branch block, or if the patient has ST segment elevation in 2 or more contiguous leads, then we say the patient has a STEMI, and again, anybody that's got a STEMI will have an increase in their cardiac markers. So again, this is important because when we talk about triaging these patients, it depends on what kind of acute coronary syndrome they have as to what we do with them. So in order to make the diagnosis of unstable angina, remember that we said the patient has either a normal EKG or they have poorly defined or transient EKG changes and their cardiac markers are negative. If the patient has ST depression in 2 or more contiguous leads or dynamic T-wave changes and an increase in their cardiac markers, we call that a non-STEMI. And finally, we said a STEMI was ST segment elevation in 2 or more contiguous leads or a new onset left bundle branch block and positive cardiac markers. Okay, now remember that those 3 diseases are not 3 distinct and separate diseases. In other words, you don't get unstable angina, or you don't follow a different path and get a non-STEMI, or follow a different path and get a STEMI. It's all one disease. What it boils down to is where we catch the patient at. So if we look at this graphic down here in the left lower part of the screen, this is kind of the presentation and the process that someone goes through as they get arteriosclerosis or arterial disease. So if we start up in the left upper corner of that graphic, you see that that's a nice, normal, healthy lumen. That's a beautiful, say, coronary artery in somebody that's probably in this country, somebody that's probably 2 years old. Now, as we shift to the left, you see that as we are exposed to high lipid diets and we're exposed to lots and lots of fat and things like that, we actually start to get plaque, and those plaque actually start to form this hard mesh around them. And so this is probably what most of us, our coronary arteries look like in the U.S. by the time we're like 5 years old. Now, as that plaque builds over time, it gets bigger and bigger and bigger until it gets to the point where it starts to occlude blood flow. When it very first starts to occlude blood flow, we only see symptoms when the heart has an increased demand. So for instance, when we talk about the patient who's nice and healthy, or the patient who's got stable angina, that patient, when they're just sitting around doing nothing, there's plenty of blood flow to meet all of the demand of the heart. So the patient doesn't have any symptoms. But all of a sudden, when the patient starts exerting themselves, when they start exercising, whether it's walking upstairs or whether it's mowing the lawn or whatever, all of a sudden heart rate has an increased workload. So heart rate goes up, stroke volume goes up, and lo and behold, now with this stable angina, there's enough of a plaque that we don't have enough blood flow to get through to meet the demands of the heart. So what do we see? Patient starts to have chest pain, patient starts to get short of breath, gets diaphoretic, blah, 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 blah. Now, the hallmark of stable angina is the fact that it's predictable. And when I say predictable, predictable means that you can predict when it's going to come on, and you can predict what's going to make it go away. So with stable angina, we may see that the patient has chest pain, but they know that it only comes on after they do 10 minutes of exertion, and they know that if they sit down for 5 minutes and they pop a nitro, it'll go away. That's classic stable angina. Now, as the disease progresses, what ends up happening is that plaque actually ruptures, and when that plaque ruptures, platelets start to adhere to the open collagen that's inside that plaque. Well, those platelets take up space, and so when those platelets take up space, it further lumens the blood vessel, or it further narrows the lumen of the blood vessel. And so lo and behold, what we see is all of a sudden the symptoms change. And that is the hallmark of unstable angina. It's the patient who has stable angina who has a change in their symptoms. So all of a sudden, the guy that used to be able to walk up 5 flights of stairs before he got chest pain, now he walks up 3 flights of stairs and he gets chest pain. Or the patient who used to be able to sit down for 10 minutes and take a nitro, now he takes a nitro and crap, the pain's not gone, it's still there. So he takes another one and it's still there. Something has changed in the symptomology. That's the hallmark of unstable angina. Now, as those platelets start to adhere to that collagen, that activates the platelets. It turns them on. And as those platelets turn on, they actually start the clotting cascade. And the clotting cascade actually starts the formation of a thrombus or a blood clot. If that blood clot actually gets big enough, what we'll see is we'll actually see that the patient will transition from unstable angina into a non-STEMI. And remember, the way we diagnosed a non-STEMI was the patient had ST depression in 2 or more contiguous leads or dynamic T-wave changes and had an increase in their cardiac enzymes over time. Now, if that thrombus becomes big enough that it completely occludes the blood vessel, then obviously we get a STEMI. This is where we've got complete occlusion of the blood vessel and the patient has complete blockage, and so we see ST elevation in 2 or more contiguous leads. We see that the patient has a new onset bundle branch block, and we know that this patient has a critical life and death emergency. If we don't reperfuse that coronary artery, then that patient is going to have a massive MI that can cause death. Now we've talked a lot about these cardiac enzymes. Let's really look at what makes up our cardiac enzymes. Let's talk about those for just a few seconds. When we talk about cardiac enzymes, probably the best way to start is by looking at what comes up first. And if you look at the graphic that's directly below me, this actually breaks up your enzyme presentation based on hours, and it breaks it down by myoglobin, CKMB, and troponin. So let's talk first about myoglobin. Myoglobin is actually the very first enzyme to go up. It goes up the quickest. It goes up very quickly, usually within the first hour. But most institutions don't even look at the myoglobin anymore. And there's a reason why. Remember that myoglobin is just like hemoglobin, but it's inside a muscle. It does the same thing that hemoglobin does. It stores oxygen. It's got the same purpose in life that hemoglobin does. It's just in muscle instead of in the blood. The problem with myoglobin is that it's in all muscle, especially there's lots and lots of it in your skeletal muscle. So if I walk up to you the day before you present to the ED and I punch you in the chest real hard or punch you in the arm real hard, then lo and behold, the next day in the ED, you're probably going to have an increase in your myoglobin. So since myoglobin is so non-specific, most institutions don't even look at it anymore. Most places don't even pay any attention to it, and most hospitals, it's not even part of their cardiac panel anymore. But you may find some institutions that still use it. The hallmark for years was actually the CKMB. Remember when we talk about CK, there's 3 types of CK. There's CKBB, there's CKMB, and there's one other type of CK. The big one that we're the most focused on, though, for cardiac is CKMB. CKMB is specific to cardiac muscle. And CKMB is actually a biomarker that exists in cardiac muscle, and when cardiac muscle it becomes hypoxic and dies and ruptures, that CKMB is released into the bloodstream. And for years, we thought this was like the coolest thing in the world. We thought this was better than sliced bread, and we did a lot of our treatment focused on the CKMB. We've actually found something that works even better than that. And actually the big thing now that everybody focuses on is the troponin. Troponin is also a biomarker. It's also an enzyme that exists in cardiac muscle tissue. And when cardiac muscle tissue ruptures and releases troponin into the bloodstream, we have an increase in the troponin. Okay, well that's the same thing as CKMB. So what makes troponin better? What makes troponin better is we can measure it much more sensitively than we can measure CKMB. So we can actually identify patients now that have such small amounts of ischemia that we can't even see it with the CKMB, but we can see it with the troponin. Now when we talk about troponin, it's broken down into 2 types, troponin I and troponin T. And the big thing to remember about your troponin is that it takes such a small amount of cardiac tissue becoming hypoxic to release troponin that not only will an MI cause an increase in troponin, but any time the heart becomes ischemic, it's going to release troponin. So what in the world else would cause the heart to become ischemic? Well, anything that causes the whole body to become ischemic. If you have a patient who's been in cardiac arrest, they're going to have an increase in their troponin. If you have a patient who's been defibrillated, they're going to have an increase in their troponin. If you have a patient who's in septic shock, they're going to have an increase in their troponin. So the cool thing about troponin is it's so sensitive that we can see increases with just the most minuscule amounts of cardiac hypoxia. But having said that, remember that just because the troponin is up doesn't necessarily mean that the patient's having an MI. Anything that causes massive tissue hypoxia, with that including hypoxia of the heart, is going to have an increase in the troponin. Now, the other thing that you'll see is that we occasionally use the last biomarker that I mentioned last because it's kind of the most worthless, is actually something called the LD1 or the LDI. When we talk about the LD, for it to come up usually takes 10 to 12 hours, so it's really kind of old and worthless, and we don't even usually use that one anymore. So again, the first thing that elevates, the thing that elevates the fastest, is going to be the myoglobin. But again, that's not specific, so just because the myoglobin's up is not... While that is very sensitive for an MI, it's not specific for an MI. The CK and the CKMB and the troponins come up very similar in the first couple hours. Usually we'll see that those will have been up by 4 hours. And remember that the troponin, we can measure that at a much more sensitive level than the CKMB. So if the troponin's up but the CKMB is not up yet, we'll still assume that that's positive cardiac enzymes. And one other last thing that's worth mentioning about the troponin is it's also what lasts the longest. The troponin stays around a long time. So like if you have somebody who presents who was complaining of chest pain 3 or 4 days ago and now they still just don't feel good and now they're short of breath and everything else, and you look and their CKMB is normal but their troponin is high, that may be proof that they had an MI several days ago. Okay, so let's talk about locations for infarctions real quick. We'll start by talking about the anterior septal MI. When we talk about the anterior septal MI, it depends on the book you read. Some books break down the anterior section and the septal section into two different sections. They say that the septal section is one section and the anterior section is the other. I don't typically recommend that, and the reason why is because remember with MIs, the whole focus in life, the big thing we care about is which blood vessel is blocked. And when we talk about the anterior surface of the heart and when we talk about the anterior part of the septum, those are both supplied by the left anterior descending. And so when we have a left anterior descending MI, that can affect both the left anterior portion of the ventricle and it can supply the septum. People that divide it up will usually say like, well, the septal part of the MI, we would look at at our leads V1 and V2. The anterior part, we would look at leads V3 and V4. And we all know that when we're looking for MIs, we're looking for EKG changes in two contiguous leads. Well, if you break it up into two separate sections, the septal section and the anterior section, then by definition, V2 and V3 would not be contiguous leads. But they are contiguous leads. They both look at the front surface of the heart. They both look at areas that are perfused by the left anterior descending. So I just lump my anterior and septal leads together into one. Now when we talk about other things that are supplied or other things that become compromised with an anterior and septal MI, one of the big things to remember is that anterior septal MIs often involve ruptures of papillary muscles. And papillary muscles are important because they're what keep valves from flipping over on themselves and inverting. So when we talk about anterior septal MIs, especially massive anterior MIs, we really want to be watching for patients to go into CHF. That's not an uncommon thing with an anterior MI. Now when we talk about a lateral MI, remember a lateral MI is when we have an occlusion of the lateral part of the heart. And the vast majority of the time, most of our lateral MIs are actually caused by an occlusion of the left circumflex. There are some small parts of the left lateral wall that are supplied by branches that come off of the LAD, but for the most part, the vast majority of our lateral MIs are caused by an obstruction of the circumflex. Now, when we talk about those, remember with the circumflex, anywhere from 40 to 49% of patients get the vast majority of their blood flow to the posterior part of their heart from their circumflex. So by definition, if I've got a complete occlusion of the circumflex in 40 to 49% of people, that also means that I'm going to have a posterior MI. Now when we talk about inferior MIs, remember the inferior MIs are caused by an obstruction of the right coronary artery. So when we talk about the right coronary artery, remember again it's important that we think about all the things that it feeds. As soon as we identify that the patient has an inferior MI, we need to start working our way backwards to find out how far up the obstruction is. So let's say you put a patient on the EKG, you look at your EKG and you say, okay, they've got an inferior MI. Well, remember the way that the right coronary artery works is we go down the right coronary artery, we have a split in the posterior descending and the right marginal. Remember that if the occlusion is above that right marginal, in other words, if it's above the split, then by definition, if the patient's got a right-sided MI, if they're in that 51 to 60% of people who have their vast majority of the blood flow in the back of their heart from their right coronary artery, then they are also going to have a posterior MI. So if we see a right-sided occlusion that involves both an inferior MI and a posterior MI, then the next thing we need to do is work our way up even further and ask ourselves, does the patient also have a right ventricular MI? If the patient's got a right ventricular MI, then we need to work our way up and ask ourselves, does it involve the electrical system? If it involves the electrical system, that tells us that the occlusion is way up the right coronary artery and that we're at the potential for loss of our SA node and our AV node. Okay, so when we look at the EKG, what are we actually looking for? Okay, we've got an EKG in front of us. What are we looking for? Well, obviously the first thing that we're looking for is ST elevation, because remember, ST elevation means the world stops and we've got to do something right now. If we've got ST elevation, we've already talked about how that means there's a complete occlusion of a coronary artery. Now remember, the ST elevation in and of itself is not significant unless it involves at least 2 contiguous leads. Remember that there has to be at least 2 leads that are elevated for us to have diagnostic ST elevation. So when we talk about ST elevation, remember we're looking for at least 1 millimeter of elevation and at least 2 contiguous leads. So we do our first sweep, we look through all of our lead groups, we look for ST elevation. The next thing that we want to do is we want to sweep and we want to look for Q waves. Well, what do Q waves tell us? Well, it depends on whether or not they're pathologic or physiologic. When we talk about pathologic Q waves, if you see a pathologic Q wave, what that tells you is that that area of the heart has already had permanent damage done, that it's irreversible, that that damage is there and you just got to live with it. When we talk about pathologic Q waves, there's 2 things that make a Q wave pathologic. The first thing that makes a Q wave pathologic is if the Q wave is wider than one little box. So when we look at our EKG, if the Q wave is wider than one little box, then that is a pathologic Q wave. The second thing that makes a Q wave pathologic is if it's deeper than 1/3 the R wave that follows it. So if it's deeper than 1/3 the R wave that's right behind it, then that is also a pathologic Q wave. Well, what if it doesn't meet that criteria? What if it's not wider than one little box, or it's not deeper than 1/3 the R wave that follows it? Then it's a physiologic Q wave. And what do physiologic Q waves mean? Nothing. That just means that that patient just happens to have a little Q wave there that's insignificant. We could care less about that. So when we make our sweep for Q waves, again, we're looking for pathologic Q waves. We're looking, is there any Q waves that are wider than one little box? Is there any Q waves that are greater than 1/3 the R wave that follows them? Now finally, the third thing that we look for as we go through our EKG is we look for ST depression or dynamic T wave changes. So ST depression, remember, in order to have ST depression, it has to be depression greater than 1 millimeter, and again, it has to be in 2 contiguous leads. And remember that when we talk about ST depression, we don't even need to bother looking for ST depression if we've already seen ST elevation. If we've seen ST elevation in 2 or more contiguous leads, we've got a STEMI, move on, forget about even wasting your time looking for ST depression. But if we've looked and there was no ST elevation, then we're looking for ST depression, because ST depression in the absence of ST elevation on the opposite side of the body means that the patient has a non-STEMI. So that patient still needs, patient still having acute coronary syndrome and very much needs care. Now the other thing that suggested to us a non-STEMI was the patient who had dynamic T-wave changes. Remember, dynamic T-wave changes, all that means is that there's been a change in the morphology of the T-waves compared to when the patient was asymptomatic. So there's the kind of the catch to dynamic T-wave changes. In order to say that somebody's got dynamic T-wave changes, you have to have an old EKG. You have to have one from when the patient was asymptomatic. So if the patient was asymptomatic before and you happen to have an EKG and you can see that the T-waves have changed in morphology, you can say that there's dynamic T-wave changes. However, if you don't have that luxury, if you don't have another EKG, then we really can't say that there's dynamic T-wave changes. So again, first thing we were looking for was ST elevation. Second thing we're looking for is Q waves. Third thing that we're looking for is ST depression or dynamic T-wave changes. Okay, let's take a break here, and when we come back, we'll actually talk about our different types of lead groups, and we'll talk about putting all this into practice.
I'd come for you, no one but you. Yes, I'd come for you, but